Hi, this is Michael Altos, and this is our last installment in the discussion on cardiac physiology. This is recording part 9. We're going to talk about some pathophysiology now and start with ischemic heart disease, which is also called coronary artery disease. And this happens when our myocardial oxygen demand exceeds the supply. Usually we're talking about patients with atherosclerosis, which is deposits of cholesterol underneath the vascular endothelium. The cholesterol starts to calcify, it leads to plaques, and these plaques obstruct blood flow. The plaques can actually lead to a clot, which we would call a thrombus, that occludes the artery, or the plaques can rupture and break away from the wall and flow until they block the artery. And a traveling plaque is usually called an embolus, so this is a coronary embolus. Plaques can also irritate the vascular wall and lead to vasospasm, making the arterial wall contract. Once again, having the same effect of all of these decrease flow of blood to the heart and cause ischemia of a portion of the myocardial tissues. What are the signs and symptoms of coronary or cardiac ischemia? Well, the first and most commonly known is angina. Angina typically presents as pain in the chest, radiating to the left arm or shoulder, the neck, or the face, when coronary oxygen demand exceeds supply. Symptoms of angina can be exacerbated by increased activity or stress, emotions, cold temperatures, or having a full stomach. Angina is treated acutely with nitrate vasodilators like nitroglycerin, and chronically it's treated with ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. Beta blockers may also be useful because they decrease cardiac sympathetic activity, thus decreasing oxygen demand. And angina is usually classified as stable or unstable. Stable angina predictably comes on with exercise or rest or stress and is relieved with rest, or unstable angina, which comes on even at rest. We also talk about angina equivalents. Dyspnea, or shortness of breath, is a good example. Diaphoresis, or even just extreme fatigue, may be signs that a patient is experiencing myocardial ischemia. There can also be silent angina, that is, no symptoms, despite the fact that the patient is having myocardial ischemia. Sometimes we can detect ischemia by looking at cardiac markers. Damaged myocytes will release cardiac enzymes and their cell contents into the plasma. So we may draw serum levels of troponin or cardiac myoglobin. In general, cardiac troponin levels greater than the 99th percentile of the upper reference limit suggest a myocardial infarction. But keep in mind that not every troponin elevation is due to myocardial infarction. If the troponin is only slightly elevated, or if it's elevated but remains constant, there may be other causes, and these could include heart failure, sepsis, pulmonary embolism, pulmonary hypertension, renal failure, rhabdomyolysis, diabetic ketoacidosis, myopathies, and endocarditis. Now let's define some terms. The first is acute coronary syndrome. This just means any suspicion or confirmation of myocardial ischemia. It's not a very specific term. It includes STEMI, NSTEMI, and unstable angina. In unstable angina, which we have already defined, there may or may not be EKG changes, but most importantly, there's no elevation in plasma troponin, at least not to any significant level. STEMI stands for ST segment elevation MI. It's usually due to the acute occlusion of a coronary artery, most commonly due to a thrombus, leading to an abrupt decrease in coronary blood flow, although it can also occur in cases of severe vasospasm, as we might see in cocaine use. The NSTEMI is a non-ST segment elevation MI. In this case, there are no diagnostic ECG changes. There is still coronary ischemia, which can lead to infarction and cell damage. It can be due to plaque rupture, leading to thrombosis, inflammation, vasoconstriction, embolization of platelets and clot fragments into the coronary microvasculature. It can also be due to decreased myocardial oxygen supply or some other kind of imbalance in the demand and supply of oxygen. When we talk about an acute myocardial infarction, we're talking about an ischemic event that leads to death of cardiac myocytes. There is a classification system for acute MI, which we'll highlight in just a moment, but most perioperative MIs are type 1 or type 2. A type 1 MI is a spontaneous MI due to atherosclerotic plaque disruption. These patients will have elevated serum troponins, plus signs and symptoms of myocardial ischemia, and it includes both STEMI and NSTEMI. Whereas a type 2 MI involves a mismatch of oxygen supply versus demand. Again, these patients will still have elevated serum troponin, together with signs and symptoms of myocardial ischemia. But you may see these terms used in the medical record, type 1 and type 2 MI. In fact, this table shows all of the different types that have been described. Type 1 and type 2 are highlighted at the top, and then other types which may occur in the perioperative period, but probably less commonly. What sort of ECG findings may occur in patients having acute coronary syndrome? This is a very complex topic, but I would just like to highlight 4 common EKG findings that you may hear about or that you may see. The first are Q waves. Q waves are part of the QRS complex, and they are pathologic if they are greater than 40 milliseconds or 1 millimeter wide, greater than 2 millimeters deep, and greater than 25% of the depth of the QRS complex. They're usually seen in leads V1 through V3, and they indicate current or prior myocardial ischemia. ST segment depression involves horizontal or downsloping ST segments at least 0.05 millivolts below the baseline in 2 contiguous leads. And this suggests subendocardial ischemia, but not yet necessarily complete cell death. ST segment elevation involves at least 1 millivolt elevation above the baseline in 2 contiguous leads. And it's a sign of acute transmural ischemia, meaning ischemia through the entire thickness of the heart, and is often associated with severe cell damage or cell death. T-wave inversions, defined as at least 0.1 millivolts in 2 contiguous precordial leads which were previously upright, suggests a prior ischemic injury. Isolated T-wave changes without ST changes as well are uncommon in acute ischemia, and we often use them as a sign that a patient may have had prior ischemia. Patients who have acute coronary syndrome may develop ventricular fibrillation. In this case, the blood supply to the infarcted area is decreased, leading to a loss of the potassium gradient in the cells, increased cell irritability, and generation of injury currents. Also, as the heart fails, the dilated ventricle also leads to creation of circular currents in the ventricular wall. Another consequence of the acute coronary syndrome may be decreased cardiac muscle function and decreased cardiac output. The ventricular wall segments that have decreased blood supply may develop hypokinetic or akinetic motion. The dead muscle cells lose their structural integrity, and the ventricular wall starts to bulge out during systole. Patients can go into cardiogenic shock, developing peripheral ischemia due to low cardiac output, and the infarcted area of the heart wall can actually rupture due to the significant cell damage. Treatment for acute coronary syndrome starts with basic supportive care: oxygen, aspirin, nitrates, morphine, and beta blockers. However, these guidelines do change frequently, and you should be aware. For example, the newest guidelines suggest giving oxygen only if the patient is hypoxic. In general, though, we do want to optimize the oxygen supply-demand balance. Anticoagulation with heparin or other agents may be appropriate when possible, as well as antiplatelet medications. Cardiology consultation for urgent angiography or thrombolytic therapy would be appropriate. How do patients recover from the acute coronary syndrome? Well, cells that have died will be replaced with fibrous scar tissue. And collateral circulation plays an important role. Tiny branches of coronary arteries will anastomose or join together. And at places where a coronary occlusion occurs, the anastomoses will dilate in order to restore blood flow to the affected area of the heart. If a patient has significant coronary blockage, there are a few treatment options. One is a coronary artery bypass graft, also called a CABG. In this surgery, a blood vessel is taken from the arm, for example, the radial artery, or from the leg, like the saphenous vein, and is grafted from the aortic root to the part of the heart that needs increased blood flow. A graft can also be taken from the internal mammary artery to bring blood from the subclavian artery to the heart. These grafts are attached to the side of the coronary artery beyond the area of occlusion in order to restore perfusing blood flow to the heart. Another alternative would be angioplasty, also called a percutaneous coronary intervention, or a PCI. In this case, a balloon-tipped catheter is advanced from some peripheral artery all the way up to the coronary artery, and the balloon is then inflated to stretch the artery open. A stent may also be deployed. A stent is simply a steel mesh tube which is left in place to hold the artery open. Now, the problem with putting a foreign body into the coronary artery is a risk of re-stenosis due to formation of scar tissue and clot around this metal structure. This risk can be decreased when using drug-eluting stents. These are stents that are impregnated with a drug that minimizes risk of clot formation. Regardless of the type of stent, patients are typically placed on dual antiplatelet therapy after stent placement. Typically, this would be Plavix and aspirin. The therapy has to go for at least 4 to 6 weeks if it's a bare metal stent, 6 to 12 months if it's a drug-eluting stent. After that time, the Plavix can be stopped, but typically aspirin is continued indefinitely. Anytime we stop a patient's antiplatelet therapy, we increase their risk of in-stent thrombosis. This is especially a risk in the perioperative period, when patients have an increased tendency to develop clot, and any stopping of antiplatelet therapy in patients with stents should be done in consultation with the patient's cardiologist. Next, let's talk about how we approach the patient who has ischemic heart disease or coronary artery disease. We'll start with the preoperative evaluation, and these guidelines do change frequently every couple years, so it's important to watch the literature. I'll try to keep up with it and update this recording as things change, but keep your eyes open. The big question we ask in anesthesia as we approach these patients is, what's the patient's preoperative cardiac risk? What's the risk that something bad will happen to their heart during the anesthetic or during the perioperative period in general? There are all sorts of risk models and calculators that exist. One that I'll focus on is called the RCRI, the Revised Cardiac Risk Index, but there are other calculators out there as well. The RCRI looks at 6 different risk factors: high-risk surgery, history of ischemic heart disease, which means having an MI, a positive stress test, chest pain from ischemia, the need to use nitrates, or having an EKG that shows Q waves. Other risk factors include history of heart failure, history of cerebrovascular disease like stroke, diabetes that needs insulin treatment, and a serum creatinine greater than 2.0. the number of risk factors has been applied by different authors to come up with an overall perioperative risk of having either, in note 1 here, cardiac death, a non-fatal MI, or a non-fatal cardiac arrest, and in column 2, their endpoints were MI, pulmonary edema, ventricular fibrillation, cardiac arrest, or complete heart block. And as you can see, as we go from 0 risk factors, where the risk is less than 1%, up to 3 or more risk factors, where the risk is between 5 and 10%, depending on the study and the criteria. How else can we assess a patient's preoperative cardiac risk? We know that the low-risk patients, from the previous slide, those patients who have a less than 1% chance of an event, don't need any further testing. The high-risk patients, the next question we have to ask is, will further testing change our management or improve their outcome? The truth is, most of the time, any additional testing would be warranted irrespective of the need for surgery. In other words, if you were the patient's primary care doctor and they came to you for a regular appointment, or if you were their cardiologist and they came to you for an evaluation, regardless of the fact that they were having surgery, just for a regular visit, would you go ahead and order testing? If you wouldn't order it for just another day, ordering it for the perioperative period is probably not indicated. Now, on the other end of the spectrum, we have patients who we call very high risk. These are patients who should be treated and optimized for their cardiac problem before they have surgery, unless it's an absolute emergency. These are patients who are having an unstable coronary syndrome, either an acute or a recent myocardial infarction, unstable or severe angina, decompensated heart failure, very significant dysrhythmias like high-grade AV block, symptomatic ventricular dysrhythmias, or supraventricular dysrhythmias with a ventricular rate greater than 100. Patients with severe valvular heart disease, these patients need to be evaluated and treated by a cardiologist before coming to the operating room, unless their surgical problem is life-threatening. So what kind of information do we want to obtain or review when we prepare these patients for surgery? In the history, we want to know about any history of angina, dyspnea, syncope, or palpitations. We are particularly interested in the patient's functional capacity, that is, their ability to tolerate exertion without having symptoms of angina or ischemia to the heart. This is usually done in METs. A MET is a metabolic equivalent. It happens to correspond to about 3.5 milliliters of oxygen uptake per kilogram of body weight per minute. 4 metabolic equivalents, or 4 METs, means the ability to climb a flight of steps, walk 4 miles per hour on level ground, vacuum the house. And if a patient has more than 4 METs, this tells us that generally they should be able to tolerate most anesthetics. This can be hard to assess in some patients, especially if they have orthopedic or pain-related limitations that make them sedentary. An EKG is not routinely indicated if patients have no symptoms and they're having a low-risk surgical procedure, although it can be useful to have a baseline EKG in case the post-operative EKG is abnormal. When we look at the electrocardiogram, we're looking for signs of ischemic heart change that indicate the patient may be at high risk for an intraoperative or perioperative cardiac event. Arrhythmias like atrial fibrillation or a left bundle branch block. Signs of ischemia like Q waves, ST segment elevation or depression, inverted T waves, or poor R wave progression would also be concerns. If the patient has an echocardiogram, we would be interested in knowing the results. This would be especially useful in patients who have dyspnea or known heart failure. Here we're trying to evaluate left ventricular dysfunction and, of course, any valvular abnormalities. A stress test can be used to stress the heart and detect ischemia, and thereby indicate the patient's cardiac functional capacity. There are many different kinds of stress tests. It can be done as an exercise stress test on a treadmill, or a chemical stress test which increases myocardial oxygen demand. And then different forms of scanning can be done to look for ischemia, whether it's the patient having symptoms like chest pain or shortness of breath, EKG or echocardiogram changes, or even nuclear scanning. Finally, coronary angiography can be used when the non-invasive testing shows a high cardiac risk. This allows them to squirt dye into the coronary vessels and see if there's any narrowing or obstructed blood flow. Now we've talked about how to stratify different patients based on their risk. We also need to stratify based on the risk that the surgery carries. Some surgeries are high risk, like emergency major surgeries, and that's especially true in elderly patients over the age of 70. Aortic or other peripheral vascular surgeries, any extensive surgery with large fluid shifts, these are all high-risk surgeries. Intermediate risk surgeries would be any intraperitoneal or intrathoracic surgery, a carotid endarterectomy, most major head and neck surgeries, as well as orthopedic and prostate surgeries. Low-risk surgeries would be minimally invasive, endoscopic surgeries, superficial biopsies, cataract surgeries, and breast surgeries. This is a summary of the latest guidelines by the American College of Cardiology, American Heart Association, for patients with coronary artery disease. And I'm going to walk through them quickly. The first question is if it's emergency surgery, because if it is, you go to surgery. If it's not an emergency, then we ask, is the patient having an acute coronary syndrome or some other very high-risk coronary event? If that's true, they should probably go have it evaluated and treated. If they're not unstable, then we estimate their clinical or surgical risk using one of the calculators. If it's less than 1%, they can probably just go to surgery. If they are at higher surgical risk, higher clinical cardiac risk, then we can ask about their functional capacity. And if it's greater than or equal to 4 METs, they're still probably safe to go on to surgery. Now, if the patient has a limited functional capacity and a high surgical risk, then we have to ask the question if further testing will impact management. Because if it won't, we'll still go to surgery. And for most low-risk surgeries, testing is very unlikely to impact management or outcomes. But if we have a patient who is at high surgical risk and very low functional capacity, and we think testing may impact care, then we would go ahead with testing like stress testing or whatever else is indicated. If it's normal, then we would go ahead to surgery. And only a patient who has an abnormal stress test would then go on for coronary revascularization, either by an angiography with a stent or a coronary bypass, and after that they could go to surgery. We will stop here. Please let me know if you have any questions about the material.